If you were the nurse for a patient going into surgery, what are the pre-op and post-op teachings you would discuss?
In my experience, one of the most important things for a successful surgery is making sure the patient feels informed and prepared. Especially when someone's anxious, taking the time to walk them through everything step by step using a structured approach can make a big difference. First, I start by understanding the situation. What kind of surgery are they having? What are their biggest concerns? Then, I can tailor my task, which is basically making sure they have all the information they need before and after the procedure. For pre-op, I'll explain things like why they can't eat or drink anything after midnight to prevent aspiration during anesthesia. We'll also go over any medications they need to stop or continue taking beforehand. Sometimes, a preoperative shower with antibacterial soap is recommended to reduce the risk of infection. And of course, I'll let them know what time to arrive at the hospital, where to go, and what to bring with them. Once they're recovered, it's all about helping them manage their post-op care effectively. That means teaching them about pain management options, including medications and non-medicinal things like ice packs. I'll also go over how to care for their surgical site and what signs of infection to watch out for. We'll talk about any activity restrictions they might have and the importance of getting enough rest to heal properly. Finally, I make sure they understand the importance of follow-up appointments so we can monitor their recovery and address any concerns they might have. And of course, I'll educate them on any symptoms that would require them to seek immediate medical attention, like a fever, severe pain, or unusual bleeding. By empowering patients with knowledge about their surgery and recovery, they feel more confident and in control. This leads to a smoother overall experience, fewer complications, and a faster return to their normal lives. It's all about working together as a team for the best possible outcome.
If you were working on a floor and a doctor came up to you and yelled at you referring to a patient that wasn't yours and you had not been taken care of, how would you respond?
I haven't experienced a situation like this before, but if a doctor came up to me and yelled about a patient that wasn't mine and whom I hadn't been taking care of, I would handle the situation with professionalism and composure. First, I would remain calm and avoid reacting defensively. I would listen to the doctor's concerns without interrupting, allowing them to fully express their frustrations. Once they finished speaking, I would politely clarify the misunderstanding by stating, "I understand your concerns, doctor, but I believe there might be some confusion. This particular patient has not been under my care. However, I am more than willing to help you find the nurse responsible for this patient or assist you in any other way." By addressing the issue calmly and offering assistance, I aim to de-escalate the situation and facilitate a resolution. Additionally, after the immediate issue is resolved, I would follow up with the doctor privately to discuss the incident and ensure that future communications are more respectful and constructive. This approach not only helps maintain a positive working relationship, but also ensures that patient care remains the primary focus.
If you were a nurse on a floor and you walked into a room and the patient was short of breath and said they were having trouble breathing, what would you access and why? You hear wheezing and you note that the patient has a history of asthma, then what would you do? How would you chart this scenario?
As a nurse on the floor, if I walked into a room and found a patient who was short of breath and reported having trouble breathing, my immediate priority would be to assess the patient's respiratory status and provide appropriate interventions. First, I would quickly assess the patient's airway, breathing, and circulation, ABCs. I would check for any visible obstructions in the airway, observe the patient's breathing pattern, rate, and depth, and listen for any abnormal breath sounds, such as wheezing, which can indicate an obstructive process like asthma. I would also observe for signs of respiratory distress, such as cyanosis, use of accessory muscles, and changes in the level of consciousness. Given the patient's history of asthma and the presence of wheezing, I would then perform a focused respiratory assessment. This would include auscultating the lungs to determine the extent and location of the wheezing and to check for other abnormal breath sounds, such as crackles or decreased breath sounds, which might suggest additional complications. I would also assess the patient's oxygen saturation using a pulse oximeter to gauge their oxygenation status. Next, I would ask the patient about any triggers or recent activities that might have precipitated the asthma attack and inquire about their usual asthma management plan, including any prescribed medications and their recent use of inhalers or nebulizers. I would also review the patient's medical record for their asthma action plan, which typically outlines the steps to take during an exacerbation. To address the patient's immediate needs, I would administer supplemental oxygen to help alleviate hypoxia, starting with a nasal cannula or mask, depending on the severity of the patient's condition. Assist the patient in using their prescribed bronchodilator inhaler, such as albuterol, to help relieve bronchoconstriction. If the patient is unable to use the inhaler effectively due to severe distress, I would prepare and administer a nebulized bronchodilator treatment. Monitor the patient's response to the treatment closely, looking for improvement in breathing, reduction in wheezing, and increased oxygen saturation. If the patient's condition did not improve promptly with initial interventions, or if it worsened, I would escalate the situation by calling for additional medical support, such as a rapid response team or the attending physician, to provide more advanced interventions and possibly intravenous medications. After ensuring the patient's immediate needs were addressed, I would chart the entire scenario meticulously to provide a clear and accurate account of the events and the care provided. This would include documenting the patient's initial presentation, including the complaint of shortness of breath, the assessment findings, such as wheezing and oxygen saturation levels, the interventions performed, oxygen administration, bronchodilator use, and the patient's response to these interventions. I would also note any communications with the patient about their asthma management plan and any consultations with other healthcare providers. In the chart, I would detail the following: the time of the assessment and the patient's subjective report of difficulty breathing. Objective findings, including respiratory rate, use of accessory muscles, wheezing, and oxygen saturation levels. Interventions provided, including the type and flow rate of supplemental oxygen and the administration of bronchodilators. The patient's response to these interventions, noting any improvement or deterioration in symptoms and vital signs. Any further actions taken, such as notifying the physician or calling for additional medical support. By documenting all these details comprehensively, I ensure continuity of care and provide essential information for other healthcare team members involved in the patient's care. This thorough charting also serves as a legal record of the care provided and the clinical decisions made during the episode of respiratory distress.
If you have a diabetic patient who is not communicative, what do you do?
If I have a diabetic patient who is not communicative, my primary concern would be to assess and address any immediate medical issues that could be causing their non-communicative state. The first step is to evaluate their level of consciousness. I would check if the patient is responsive to verbal or physical stimuli, such as calling their name or gently shaking their shoulder. If the patient does not respond, this could indicate a serious underlying condition that needs urgent attention. Next, I would assess the patient's vital signs, including blood pressure, heart rate, respiratory rate, and oxygen saturation. Monitoring these parameters can provide clues about the patient's overall condition and help identify any immediate threats to their health. Given the patient's diabetic status, it is crucial to measure their blood glucose level promptly. Hypoglycemia, low blood sugar, is a common and potentially life-threatening condition in diabetic patients that can lead to altered mental status or unresponsiveness. If the blood glucose level is found to be low, I would administer a quick source of glucose, such as glucose tablets or a glucose gel, if the patient can safely swallow. If the patient is unable to swallow, I would follow protocol for administering intravenous glucose or glucagon, depending on the severity of the hypoglycemia and the resources available. Conversely, hyperglycemia, high blood sugar, can also cause changes in mental status and must be addressed. If the blood glucose level is excessively high, I would inform the attending physician or diabetes care team immediately to get orders for appropriate interventions, such as insulin administration and hydration. While addressing the blood glucose levels, I would also assess for other potential causes of non-communication, such as infection, stroke, or other metabolic imbalances. A thorough physical examination is necessary to identify any signs of infection, such as fever, redness, swelling, or discharge, which might indicate a need for antibiotics or other treatments. Throughout this process, I would maintain close communication with the healthcare team, including notifying the attending physician and possibly calling a rapid response team if the patient's condition appears critical. Continuous monitoring of the patient's vital signs and responsiveness is essential to detect any changes that might require further intervention. Additionally, I would review the patient's medical history and current medication regimen to identify any recent changes or potential side effects that could contribute to their current state. Consulting with family members or caregivers, if available, can also provide valuable information about the patient's baseline behavior and any recent concerns or changes they may have noticed. Finally, I would ensure that all interventions and observations are meticulously documented in the patient's medical record. This includes recording the initial assessment findings, blood glucose levels, interventions performed, the patient's response to these interventions, and any communications with the healthcare team. Accurate documentation is crucial for continuity of care and provides a detailed account of the patient's condition and the care provided. In summary, addressing a non-communicative diabetic patient involves a systematic assessment of their level of consciousness, vital signs, and blood glucose levels, followed by appropriate interventions to manage hypoglycemia or hyperglycemia, and continuous monitoring and documentation to ensure comprehensive care and patient safety.
If you're a nurse on a floor and one patient is experiencing transfusion reaction, another patient that is in shock, and a third patient with low blood pressure, who do you see first and why?
If I am a nurse on a floor with one patient experiencing a transfusion reaction, another patient in shock, and a third patient with low blood pressure, I need to prioritize care based on the severity and immediacy of each condition. The first patient I would attend to is the one experiencing a transfusion reaction. Transfusion reactions can rapidly become life-threatening and require immediate intervention to prevent severe complications or death. Symptoms of a transfusion reaction can include fever, chills, itching, rash, shortness of breath, hypotension, or hemolysis. The most urgent steps would be to stop the transfusion immediately, maintain intravenous access with normal saline to keep the vein open, and call for assistance from other healthcare providers. Monitoring the patient's vital signs, providing oxygen if needed, and preparing to administer medications such as antihistamines, corticosteroids, or epinephrine, depending on the type of reaction, are crucial steps. The prompt cessation of the transfusion and supportive care can prevent the progression to more severe symptoms such as anaphylaxis or acute hemolytic reactions. Next, I would attend to the patient in shock. Shock is a critical condition that indicates inadequate blood flow to organs and tissues, which can rapidly lead to organ failure and death if not treated promptly. Symptoms of shock can include hypotension, tachycardia, altered mental status, cold and clammy skin, and decreased urine output. The priority in managing shock is to identify and treat the underlying cause, whether it is hypovolemic, cardiogenic, distributive, or obstructive shock. Immediate interventions would include ensuring adequate airway and breathing, providing oxygen, establishing intravenous access, and administering fluids or medications as appropriate. If the patient is hypovolemic, rapid fluid resuscitation with crystalloids or blood products may be necessary. If the cause is cardiogenic, medications to support heart function might be required. The goal is to stabilize the patient's hemodynamic status and improve tissue perfusion. Finally, I would attend to the patient with low blood pressure. While hypotension can be a sign of a serious underlying condition, it is not immediately as critical as a transfusion reaction or shock unless accompanied by symptoms such as altered mental status, chest pain, or severe weakness. The first step in managing a patient with low blood pressure is to assess their overall clinical status and look for potential causes. This involves taking a detailed history, performing a physical examination, and possibly ordering diagnostic tests. Interventions may include administering fluids to increase blood volume, adjusting medications that may be contributing to the low blood pressure, or other treatments based on the underlying cause. Monitoring the patient's vital signs closely to detect any changes that might indicate worsening condition is also important. In summary, I would prioritize seeing the patient with the transfusion reaction first due to the immediate risk of severe complications or death if not addressed promptly. I would then attend to the patient in shock, as shock represents a life-threatening condition requiring rapid intervention to prevent organ failure. Lastly, I would see the patient with low blood pressure, ensuring that while their condition is managed appropriately, they are continuously monitored for any signs of deterioration. This approach ensures that the most life-threatening conditions are addressed first, optimizing patient outcomes and maintaining patient safety.
If you have an older patient that has been in bed 2 weeks, is short of breath, and has a respiratory rate of 40, what do you do?
When dealing with an older patient who has been bedridden for 2 weeks, is short of breath, and has a respiratory rate of 40, my immediate priority is to assess and stabilize their respiratory status. A respiratory rate of 40 breaths per minute is significantly elevated and suggests severe respiratory distress, requiring prompt intervention. First, I would quickly assess the patient's airway, breathing, and circulation, ABCs. Ensuring the airway is clear is essential. I would look for any signs of airway obstruction and listen for abnormal breath sounds, such as wheezing, crackles, or diminished breath sounds, which can indicate different underlying issues like bronchospasm, fluid in the lungs, or pneumonia. Observing the patient's overall appearance, I would look for signs of cyanosis, bluish discoloration of the lips or skin, use of accessory muscles, and any evidence of increased work of breathing. Given the patient's symptoms and history of being bedridden, I would suspect possible complications such as pneumonia, pulmonary embolism, or exacerbation of a chronic respiratory condition like COPD. To gather more information, I would quickly measure the patient's oxygen saturation using a pulse oximeter. If the oxygen saturation is low, supplemental oxygen would be administered immediately to improve oxygenation. The method and amount of oxygen delivered would depend on the severity of the hypoxia and the equipment available, ranging from a nasal cannula to a non-rebreather mask for more severe cases. Simultaneously, I would ensure the patient is in a comfortable and optimal position to ease breathing, typically sitting upright if they can tolerate it. This position helps expand the lungs and improve ventilation. While providing these immediate interventions, I would notify the attending physician or the rapid response team to get additional support and further medical evaluation. Describing the patient's condition accurately, including their respiratory rate, oxygen saturation, and any other relevant symptoms or history, would be crucial for the medical team to understand the urgency of the situation. Additionally, I would prepare for potential diagnostic tests as ordered by the physician. These might include a chest X-ray to look for pneumonia or other lung conditions, blood tests such as arterial blood gases to assess the severity of the respiratory distress, and possibly a D-dimer test if a pulmonary embolism is suspected. Monitoring the patient continuously is vital to detect any changes in their condition. This involves regular checks of their respiratory rate, oxygen saturation, heart rate, and overall appearance. If the patient's condition deteriorates despite initial interventions, I would be prepared to escalate care, which could include advanced airway management or transferring the patient to a higher level of care such as the intensive care unit, ICU. Throughout this process, I would ensure all interventions and observations are meticulously documented in the patient's medical record. This includes the initial assessment, oxygen administration, the patient's response to interventions, communications with the healthcare team, and any orders received and carried out. Comprehensive documentation is essential for continuity of care and provides a clear record of the patient's clinical status and the care provided. In summary, managing an older patient with significant respiratory distress involves rapid assessment and stabilization of their respiratory status, immediate interventions to improve oxygenation, continuous monitoring, and prompt communication with the healthcare team to ensure timely and appropriate medical management. This approach aims to stabilize the patient's condition and prevent further deterioration, ensuring the best possible outcome.
If you are a nurse on a floor and the ventilator alarm is sounding and the high-pressure alarm is sounding, what do you do?
If I am a nurse on a floor and the ventilator alarm is sounding, specifically the high-pressure alarm, my immediate priority is to assess and address the cause of the alarm to ensure the patient's safety and adequate ventilation. First, I would quickly go to the patient's bedside to assess their overall condition. I would check for signs of distress, such as agitation, cyanosis, or increased work of breathing. These signs can indicate that the patient is not receiving adequate ventilation, which requires prompt intervention. Next, I would examine the ventilator settings and the circuit for any obvious issues. The high-pressure alarm typically indicates that there is increased resistance to airflow or decreased compliance in the patient's lungs. Common causes include obstructions in the airway, such as mucus plugs, kinks in the ventilator tubing, or the patient biting the endotracheal tube. I would look for these potential obstructions and correct them if found. For instance, I would ensure that the tubing is not kinked and that the patient's head and neck are positioned properly to facilitate airflow. I would then listen to the patient's breath sounds using a stethoscope to identify any abnormalities such as wheezing, crackles, or absent breath sounds. Wheezing might suggest bronchospasm, while crackles could indicate fluid in the lungs. Absent breath sounds on one side might indicate a pneumothorax, which requires immediate medical attention. If the issue is not immediately apparent or easily corrected, I would manually ventilate the patient using a bag valve mask, BVM, to ensure they receive adequate oxygenation and ventilation while investigating further. Manual ventilation allows me to feel the resistance and confirm whether the issue is related to the ventilator or the patient's airway/lungs. Simultaneously, I would call for help from respiratory therapy and the attending physician to assist in diagnosing and resolving the problem. Describing the patient's condition and the steps I have already taken will help the team understand the urgency and nature of the situation. Continuously monitoring the patient's vital signs, including oxygen saturation, heart rate, and blood pressure, is crucial to detect any signs of deterioration. If the patient's condition worsens, I would be prepared to take further action, such as increasing the oxygen concentration or administering medications as ordered by the physician. Throughout the process, I would ensure that all interventions and observations are meticulously documented in the patient's medical record. This includes the initial assessment, actions taken to address the high-pressure alarm, the patient's response to these actions, and any communications with the healthcare team. In summary, addressing a ventilator high-pressure alarm involves quickly assessing the patient's condition, checking for obstructions or issues with the ventilator circuit, manually ventilating the patient if necessary, calling for additional support, continuously monitoring the patient's vital signs, and thoroughly documenting all actions and observations. This approach ensures the patient receives timely and effective care, preventing complications and maintaining their respiratory function.